Welcome, everyone. Good afternoon, good evening for everyone who's tuning in for this webinar tonight. Thank you for joining us for the Canadian Liver Foundation and the Canadian Association for the Study of the Liver Ask the Expert webinar on liver cancer. My name is Nem Maximovich. I am the Senior Manager of Support and Education at the Canadian Liver Foundation, and I will be the moderator and host for this webinar. I'd like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. We are joined tonight by our presenters, Dr. Mayur Brahmania from the University of Western Ontario in London, Ontario, and Dr. Jennifer Flemming from Queen's University in Kingston, Ontario. As for our agenda, we will have the two speakers complete their talks prior to moving on to a question and answer portion. Please feel free to use the comment feed to ask your questions during the presentation, and note that questions will be answered following each speaker's presentations. This webinar will also be available post-event on the Canadian Liver Foundation website, as well as our Facebook and YouTube pages in the coming days. So for those who may not be familiar with the Canadian Liver Foundation, or if it's your first time tuning in to a CLF webinar, I'd like to provide you with a brief overview of who we are and what we do. The CLF was established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. The Canadian Association for the Study of the Liver, also known as CASL, is a nonprofit organization that seeks to eliminate liver disease through also research, education, and advocacy. Its members include a wide variety of hepatologists, gastroenterologists, pathologists, pediatricians, radiologists, scientists, surgeons, trainees, and others. At this time, I would like to welcome our first speaker for tonight's webinar, Dr. Jennifer Flemming. Dr. Flemming joined the Faculty of Medicine at Queen's University in 2014 as a member of the Division of Gastroenterology. She completed medical school at Dalhousie University and completed internal medicine and gastroenterology training at Queen's University. She then spent 2 years at the University of California, San Francisco, completing subspecialty training in hepatology and liver transplantation, as well as obtaining her master's degree in advanced clinical research. Dr. Flemming is the first in Canada studying the links between cirrhosis and biliary tract cancer from both a clinical and population perspective. Long-term, Dr. Flemming hopes to use the results of her population-based research to justify the development of chronic disease management strategy for all Canadians living with liver disease. I will now pass it to Dr. Flemming.
Thank you, Nem. I'm just going to share my slides here. Okay, so I would like to thank CASL and the CLF for the invitation to present today. And I would like to thank the audience for your participation as well, as it's very important to make sure that our patients, family members, caregivers are informed about liver disease. I don't have any disclosures for this presentation. So over the next 15 to 20 minutes, I'll be completing part one, where I will give an overview of the liver and what it does. Then we will talk about what is cirrhosis and how does it happen. And the rest of my talk will be talking about the topic of today, which is hepatocellular carcinoma. We'll review signs and symptoms, screening for HCC, as well as risk factors, and then staging. Part two, I will pass on to my colleague, Dr. Brahmania, who will talk about treatment options for hepatocellular carcinoma. So first, let's talk about the liver. The liver is the largest solid organ in the body, and it's the only organ in the body with a dual blood supply. And I'm going to take a little bit of time talking about the blood supply today because it's very important to understand why patients with liver disease develop complications, and also why we do some of the treatments and investigations that we do for liver cancer. So over here on the right side here, although the majority of organs in the body are supplied by the systemic circulation, the liver is the only organ that receives most of its blood from the portal circulation, especially in the form of the portal vein, which is down here in blue. So how the liver gets its blood supply is blood from the portal vein brings blood from the bowel into the liver. The blood then interacts with the hepatocytes, which are the liver cells within the liver, where the liver performs over 500 different unique functions. Once the blood has passed through the hepatocytes, it then passes up through the hepatic veins, which come up here and flow back to the heart. And this blood that has exited the liver then gets pumped around to the rest of the body. The other important thing I would like to highlight is that the liver is one of the only organs that can regenerate. And it can regenerate in response to liver injury, but it can also regenerate after surgery or removal of part of the liver, where after several months, the liver can grow back to its full size. Here I would like to highlight the 6 major functions of the liver. The first 2 are related to detoxification and filtration of blood as it enters from the portal vein into the liver. The liver is also responsible for manufacturing many useful products that are used throughout the body. Specifically, they are used to manufacture our blood coagulation factors, as well as proteins that are in our blood. It also is used for storage. It stores important substances such as glycogen, which we use for energy, as well as vitamin A. It manufactures our bile. Our bile is the fluid that is used to digest our food. And finally, it's used in the regulation of temperature control. Now turning to cirrhosis. Cirrhosis is severe scarring of the liver. Here on the left-hand side, I have a picture of a normal liver, and in a normal liver without disease, there should be no scarring. In patients with chronic liver diseases, they develop insult and inflammation within the liver on a long-term basis. In Canada, the most common chronic liver diseases are chronic viral hepatitis B and C, non-alcoholic fatty liver disease, or NAFLD, and alcohol-associated liver disease. These 3 chronic liver diseases account for almost 90% of all causes of cirrhosis. However, there are many other important causes of cirrhosis that we also recognize and manage, such as autoimmune hepatitis, primary sclerosing cholangitis, primary biliary cholangitis, hemochromatosis, alpha-1 antitrypsin deficiency, and very rarely, certain drugs can cause inflammation and scarring of the liver. So in patients who have chronic liver disease, typically over 10 to 30 years, the recurrent insult and inflammation forces the liver to try and repair and regenerate itself. However, in the process of doing that, certain individuals will also develop scarring of the liver. It's very similar to when you get a cut on your skin and your body tries to heal itself and scar tissue is formed. Once a certain degree of scarring develops, that's when we say somebody has cirrhosis of the liver. If we were to look under the microscope, this is what we would see. So this here is a normal liver. You can see that these red cells here are the hepatocytes. This tube in the middle of the 2 sets of hepatocytes is called the sinusoid, and that's where your bile flows to try and help you digest food. And in between the hepatocyte and the sinusoid, there's this very important cell here in green called the hepatic stellate cell. It stores our vitamin A, but it's also responsible for scar tissue formation in the liver. In individuals with chronic liver diseases, as I mentioned earlier, this stellate cell becomes activated. When this stellate cell is activated, it begins to produce substances which form scar tissue, which is highlighted here in the blue. Once the scar tissue begins to form, it forms in between the hepatocytes and the sinusoids here, which alters the architectural nature of the liver. Once a certain degree of scar tissue develops, as I mentioned, we call this cirrhosis, where instead of the hepatocytes and the sinusoids being nicely lined up together, there is large bands of scar tissue which form. And this extensive scarring of the liver can lead to changes in liver function, liver failure, and predispose people to liver cancer. This is a schematic outlining the natural history of chronic liver disease in cirrhosis. The first stage is termed compensated cirrhosis, where people have cirrhosis based on the amount of scar tissue that they have in their liver, but they haven't yet developed any symptoms. If you took 100 people over a year with compensated cirrhosis without symptoms, 5 of those people, or 5%, would develop what we call decompensated cirrhosis, where symptoms start to develop. The symptoms that develop in decompensated cirrhosis are related to variceal hemorrhage or bleeding, ascites, which is fluid in the belly, hepatic encephalopathy, which is confusion, hepatorenal syndrome, which is injury to the kidney, or hepatocellular carcinoma. I'll be touching on these briefly again in the next several slides. I would also like to highlight that once an individual develops decompensated cirrhosis, there is still an opportunity because of the liver's ability to repair and regenerate that individuals may revert back to being compensated. This is most often seen in individuals who have alcohol-associated liver disease who are able to obtain abstinence, patients with viral hepatitis B and C who have been treated with antiviral therapy, or other chronic liver diseases where we have medications which can help, such as steroids for autoimmune hepatitis. I now want to go back to the blood flow of the liver because it will help you to understand why these complications develop or decompensation occurs. So again, here on the left, we have a normal liver. This is the portal vein, and this is the blood flowing up into the liver. And in a normal liver, this blood flow moves very easily. We can use the analogy in this case that the liver is like a sponge. And if we were to take a hose of water and pour it through the sponge, it would easily flow to the other side. This is in contrast to patients who have cirrhosis. Once scarring develops, it's much more difficult for blood to flow through the portal vein because of all the distortion related to the scar tissue. This results in high pressures within this portal vein, which we call portal hypertension. To use the same hose analogy, now instead of your liver being like a sponge, your liver is like a rock. And so when you try and pour water through this rock, it backs up with pressure and causes portal hypertension. This is what leads to decompensated cirrhosis. Very commonly, patients who develop decompensation will get ascites, which is a term to describe fluid in the belly. And that is because of the high pressures that develop in and around the liver. The second one is hepatic encephalopathy. This is confusion. This is because the blood is not able to adequately flow through the liver. The liver is not able to detoxify the blood, and therefore these toxins back up into the bloodstream and cause confusion. Finally, varices. This is because, again, of a backlog of pressure where blood, instead of flowing through the liver, goes to veins around the esophagus, which is the swallowing pipe, or in and around the stomach, and they are like balloons. If they get to a certain pressure, they can be at risk of popping and bleeding. Now we'll switch our focus to the complication of the day, which is hepatocellular carcinoma. Hepatocellular carcinoma is a cancer that develops first within the liver. And cirrhosis is the most common risk factor for individuals to get HCC. For instance, 90% of all individuals with HCC have underlying cirrhosis. However, there are other recognized risk factors for developing HCC. These include older age, being of male sex as opposed to female sex, patients who have diabetes, those who have developed decompensation of their cirrhosis, individuals who have chronic viral hepatitis B or C are at higher risk than other causes of liver disease. However, this risk can be dramatically reduced in individuals who are on antiviral therapies or in patients with hepatitis C who have been cured of their disease. Finally, we know that in patients who have a family history of HCC, the risk of cancer is higher. Despite this, only 1 to 5% of patients with cirrhosis every year will develop a cancer. The good news is HCC is curable if it's detected early. The majority of patients with HCC actually do not have any symptoms. Therefore, we can't wait until symptoms develop to find these small tumors. Therefore, it is recommended that ultrasounds with or without a blood test for a tumor marker called alpha-fetoprotein is recommended every 6 months for most patients with cirrhosis and those with hepatitis B without cirrhosis. Once you have an ultrasound for HCC screening, and if it detects a new spot in the liver or a spot that's changing, it doesn't necessarily mean that this is cancer, but it means that we have to investigate much further to make sure that we are not missing a cancer. That's why in individuals who have an abnormal ultrasound, other imaging with contrast dye, such as a contrast ultrasound, CT scan, or MRI, will help to determine if this abnormality actually represents HCC. A liver biopsy is usually not required to make the diagnosis of HCC. This is because the contrast dye studies are extremely accurate at making a diagnosis of HCC, and liver biopsies are only required in a small number of people. This again relates to the blood flow of the liver. As you remember, the liver is primarily supplied by the portal vein. However, tumors in the liver are primarily supplied by the arteries. Therefore, if a patient with cirrhosis has a contrast scan which shows that this spot in the liver lights up in the arteries but not in the veins, that is very, very suspicious for a diagnosis of HCC. Once a diagnosis of HCC is made, then we have to determine what stage of HCC the patient has. This depends on many things. First is the size, number, and location of the tumors, and whether or not these tumors extend into any of the major blood vessels within the liver, or if the tumor has traveled outside of the liver. Other important factors that are considered is if your liver is compensated or decompensated, or if you are otherwise strong and healthy, or if you have other medical conditions which could make certain treatments more associated with side effects. So how does your care team advise on the best treatment options? It's really a team effort. And each individual with hepatocellular carcinoma are discussed at multidisciplinary tumor boards. This is a weekly meeting that occurs at many hospitals around Canada and is attended by many different types of physicians and allied health providers. These include the hepatologists or the liver specialists, the diagnostic interventional radiologists who are experts in the contrast studies, hepatobiliary and transplant surgeons who are experts in surgery and transplantation, and medical oncologists and radiation oncologists who are experts in chemotherapy and radiation. And with that, I will be passing on to my colleague to talk about treatments.
Perfect. Thank you, Dr. Flemming, for that great talk. So as Jennifer mentioned, we will be passing the torch to Dr. Mayur Brahmania as our second speaker for tonight. I would like to kind of give a brief overview of Dr. Brahmania's kind of background. So he's an assistant professor of medicine at Western University, practicing in hepatology and transplant hepatology. He completed his undergraduate and medical degree at the University of Saskatchewan before starting medical residency at the University of British Columbia in internal medicine and completing a gastroenterology fellowship at the University of Manitoba. Dr. Brahmania is the current chair of the Gastroenterology Quality Improvement and Innovation Committee at the University of Western and currently focuses his research interests around quality improvement initiatives to advance and standardize quality of care in patients living with liver disease. Dr. Brahmania, over to you.
Thanks, team, and thanks, Jennifer, for that excellent overview on chronic liver disease and hepatocellular carcinoma. So I've been tasked with updating you on what the latest treatment paradigm is for HCC treatment. around the globe and especially in Canada. Here are my disclosures. I have nothing to disclose to the group regarding grants or research or any speaking fees and honoraria. So as Jennifer mentioned, once a patient is diagnosed with cancer, we usually like to group it into two types of therapy. There's either a curable form of liver cancer or a not curable type of cancer. And when we look at the curable type of cancer, there's a few type of treatments that we can give to the patient. So the first is called ablation. This is performed by interventional radiologists who specialize in two types of treatment called radiofrequency ablation or microwave ablation. As you can see from the picture on the right, they take a probe to the tumor and then usually burn the tumor to create a heat sink effect, and usually you are left with no residual tumor. This is usually a day procedure. It takes approximately 4 to 6 hours when it's all said and done. And after the patient is discharged from the hospital, they're followed up with a CT or an MRI in 1 to 3 months. Some common side effects that may happen after the RFA include back pain or fever or recurrence of cancer. If anyone does suffer any of these symptoms, it's encouraged that they contact the provider to follow up or visit their local emergency room. Another type of curable form of treatment for liver cancer is resection. And as Dr. Flemming previously mentioned, this really depends if you're healthy enough for surgery and if your liver is healthy enough to undergo a surgery. This is where a hepatobiliary surgeon can remove a small portion of the tissue or even an entire lobe. As you may remember, there's two lobes to your liver. You have a right and left lobe of the liver. Most of the liver resections are performed laparoscopically, but sometimes the surgeon may have to open the abdomen and remove the part of the lobe through that technique. Depending on the type of surgery you have, you can be in hospital from anywhere to 3 to 5 days. The side effects that you may experience from this include blood clots, infections, wound complications. Your liver may be impaired a little or underestimated, and you may develop liver failure. And ultimately, in the long term, you may develop recurrence of the cancer. Next, what we like to talk about in many of our patients is liver transplantation. Again, this is another curable type of procedure that is performed where we remove the entire liver and we replace it with a healthy donated liver. A liver transplant is only considered when the cancer is within the liver. It can't be treated by other modalities, as I previously mentioned. And it really depends on the maximum size and the number of tumors that you have in the liver that we would be able to transplant patients with. There are many things to consider when you're being assessed for transplantation, including frailty, how well your social supports are, and overall heart health. And here I'm talking about if you have major cardiovascular disease or not. This is a pretty busy figure that I'm showing here, but I wanted to show you that some of the criteria for liver transplantation varies across Canada. And you can see that there's not a homogeneous set of criteria across Canada to determine when or if you're a transplant candidate. If you're not eligible for a curable treatment, there are still non-curable treatment regimens that we can apply for the patient that can prolong survival. One such therapy is called embolization. Again, this is performed by interventional radiologists. There are two main types of embolization, with the most common being transarterial chemoembolization, or TACE, or transarterial radioembolization. Usually the patient is in the hospital for 1 to 2 days after procedure, and side effects from embolization may include liver failure and typical side effects that you may see from other chemotherapy regimens. Usually you'll have a CT or MRI in 1 to 3 months, to ensure that the area that's been treated has not recurred, or if there's any residual tissue left, that it could be ablated or treated again. Another non-curable type of treatment is radiation therapy. This is performed by our radiation oncology colleagues, and what they do is give radiation over 5 courses every other day. They really first inject the tumor, ensure that there's uptake, and so they're able to localize the radiation to specifically the tumor rather than the entire liver. This is also known as SBRT, or stereotactic body radiation therapy. Side effects to this type of treatment may include skin sensitivity, nausea, and fatigue. Usually, you'll have a CT scan in 3 months to see the treatment effect, as I spoke about with the other treatment modalities. Now, what I wanted to talk about was chemotherapy. Previous to 2018, we only had one drug called sorafenib, and that's been approved since 2008. And in the last few years, there's been an explosion of therapies and clinical trials, which really has changed the landscape of how we treat hepatocellular carcinoma. As you can see on the far left-hand side, there's been numerous drugs that have been approved in Canada, born out of large clinical trials. The latest ones include atezolizumab and bevacizumab. And you can see in the second column where we talk about notice of compliance, when the drug company has applied for approval to the Canadian government to ensure that it is safe to use for the public use. And so you can see when the NOC has been given for these drugs, which have all really been in the last couple of years. After a drug has passed the NOC, the drugs are reviewed by PCODER or CADIT, and this is really comprised of Canadian experts who would give a final stamp of approval to the drug, ensure that there's safety, there's reimbursement and economic advantages to giving this type of medication. And as you can see, a lot of these medications, again, have been approved, and typically it takes 1 year from the NOC for PCODER to give an actual recommendation. Now, as you can see in the subsequent columns here, is that many governments are acting independently, and most provinces act in accordance with each other, but there's still some provinces that don't have all therapies that are available with them. As of a few weeks ago, there's still a couple of drugs that have been approved, but still not approved by our local provinces to take in effect and for us to be able to give treatment for. Lastly, I don't want to skip over this part, but a non-curable form of treatment is still palliative care. We often think of palliative care as end-of-life treatment, but it's much more than that. A lot of our patients have difficulties with concentration, they have sleep difficulties, they have fatigue, muscle cramping is very common, sexual dysfunction, and pain. A lot of our patients have coexistent depression, and a lot of them have coexistent anxiety as well. What we know from the literature is that most of the palliative care consults occur in the last 72 hours of death, and most of the time they occur in the inpatient setting. What I wanted to get across to the audience tonight is that end-of-life planning really begins when the diagnosis is made. We know that early life, end-of-life planning reduces caregiver burden and actually improves quality of life in many other disease states, as well as liver cancer. Many of you may be wondering what the estimated survival is if you're diagnosed with cancer. Well, at the multidisciplinary tumor board rounds that we use, we usually break up our patients into these distinct categories. Now, of course, every patient does not neatly fit into these categories, but what we try to provide is always curable treatment. On the far left side, you can see that if you undergo an ablation, a resection, or a transplant, your expected survival is over 5 years. If you look at the middle column where we talk about an intermediate stage, We talked about the therapies, including chemoembolization and radiation therapy. Your median survival is around 3 years. When you look at the far right side, in stage C and D, we talked about chemotherapy, and many of the new agents that have been approved in the last year have extended this median survival time to over 18 months. And lastly, I can't forget again about palliative care, where although you might have a limited life survival around 3 months, you can still provide good quality of life to these patients with liver cancer. What we foresee in the future in terms of what's happening in clinical research and how we're pushing the boundaries of treatment is when you look at the intermediate stage or even the late stages of liver cancer, we want to get patients to the left side of the curve where we can provide them with curative techniques. That's where our latest research is being focused on, and how to keep patients healthy enough so they can undergo these curative treatments. So with that being said, I think Dr. Flemming and I would like to both thank Dr. Tandon and her team at the University of Alberta for creating this great patient website called cirrhosiscare.ca. And we would also like to thank our patients, our families that are participating in research, philanthropy, and continued advocacy. HCC is an orphan disease, and it takes patients and families to advocate, as physicians can't do this on our own. And so we appreciate this and your continued support through the Canadian Liver Foundation, as well as through our main liver association in Canada called CASL. Thank you.
Great. Thank you for that, Dr. Mayur and Dr. Flemming. We would go into we're going to go into our kind of question and answer kind of section now, and we'll get both speakers on the screen. So definitely a lot of information that we were able to cover there. And I think some of the main questions that would pop up from the Canadian Liver Foundation perspective would be kind of long-term outcomes or quality of life. One question that did pop up earlier related around, I guess, cancers. Some cancers, people being able to battle or fight the cancer, possibly go into remission, and mentioning how the liver is a resilient organ. Is there any kind of way that somebody can battle this liver cancer and possibly be in this remission state and not see cancer long-term, or be kind of have a good quality of life for longer than 5 years? Is there any kind of, is it similar to some other cancers, or once it develops into that liver cancer stage that it's very difficult for the liver to regenerate? That was kind of one of the questions that popped up.
I can try and answer that question. Thanks, Nem. I think that's a very good question. And I think that there's many different factors that can influence whether or not people have a long-term remission and good quality of life. First off is the stage of the cancer when it's diagnosed. And the earlier, the better. When we diagnose liver cancer earlier, we have many more options for curative therapy. And that's why it's recommended that patients who are at risk of HCC, such as those with cirrhosis and hepatitis B, get screened regularly with ultrasounds every 6 months so we can find those cancers when they're small. Because if we find them when they're small and we can offer curative therapy, there is the opportunity for long-term remission. And personally, I've had patients who are 8-10 years post-resection or RFA, and if they don't have decompensated liver disease, can have really excellent quality of life. So I think the stage at diagnosis is one of the key factors. The second is, as I just mentioned, the status of the liver itself. If you have compensated liver disease where you don't have symptoms and you have good liver function, then there is the opportunity for your liver to stay healthy long-term, as long as we've treated whatever the underlying cause which caused the cirrhosis. So if it was alcohol-associated disease, being able to maintain alcohol abstinence. If you have chronic hepatitis C, getting treatment with antivirals so you can cure your hepatitis, or if you have hepatitis B, going on antiviral therapy as well. And there's many other treatments for the other liver diseases that I mentioned as well. So working closely with your care team, your hepatologist, to make sure you're doing everything you can to keep your liver healthy, eating healthy, exercising, all of those things. If you have decompensated liver disease and you have liver cancer, then it gets a little bit trickier, because even if we can cure your cancer, the underlying liver function may or may not get better. And a lot of times in those individuals, liver transplantation is really the best option for long-term remission. And median survival after liver transplantation is getting longer and longer. Within our clinic, we have patients who are 20 years post-transplant who are enjoying good quality of life. So in summary, it really depends on the stage of your liver disease or of the HCC when it's diagnosed, and whether you have compensated or decompensated liver disease.
Oh, great. Thank you for that. Dr. Brahmania, anything to add on your end?
That was an excellent summary. I think like many cancers, it's contingent on good follow-up, and like many of the cancers, usually your care provider will follow up with you at regular intervals, whether that be every 3 months, 6 months, or a year, to ensure that you are, again, getting the best treatment available for you, and ensuring that, if something does reoccur, you don't have a curative treatment, that we can get you into treatment really quickly.
Oh, great, thank you. I guess speaking of kind of having a good follow-up, in for those who are, I guess, tuning in certain rural or remote areas where they may not have as many, for example, cancer treatment centers or transplant centers, or even specialists, liver specialists for that matter, what would you recommend in terms of guidance, in terms of navigating the healthcare system as a whole once they actually obtain the diagnosis for, let's say, advanced liver disease, and they have to get screened, and they're afraid, for example, to fall through the cracks, given that they consider themselves being outside of a metropolitan city or outside of a province that kind of provides more consistent, perhaps, follow-up? Is there any kind of tips, suggestions, or kind of an outlook that you can provide to some of those patients?
I think, you bring up a very good point here. We know that there's disparities in care in those patients that with chronic liver disease, that if you live in an urban center or a population that's much smaller than an urban population. I think advocacy groups like what you're talking about, getting out education to our primary care providers and educating them on screening for liver disease, and then recognizing when those symptoms of cirrhosis are. Many smaller centers do have the capabilities to carry out ultrasound screening. So really it's about recognition about cirrhosis and subsequent care. Now, the question that you asked is a little bit more complex, because if you're in a rural town and you happen to have a small cancer that's been detected, then there are mechanisms where the patient can be referred to a tertiary care center, where you have a multidisciplinary team that can review your case. Now with the COVID pandemic and the uptake of telemedicine, the barriers have obviously reduced a lot more than they were previously pre-pandemic. But of course, there's still circumstances that can impair the care that someone receives. I don't know if Jennifer has anything to add to that as well.
No, I think that those are all great points. And I think that the take-home point for anybody living with liver disease is that you really deserve a consultation with a hepatologist or specialist who is very familiar with liver disease, to educate you about your disease and to make recommendations for screening. Now, as Dr. Brahmania said, ultrasound is the recommended screening modality. And luckily, even if certain centers don't have all of the other resources such as transplantation, RFA, TACE, etc., most centers are able to organize an ultrasound. And so, for instance, I practice at Queen's, which is in Kingston. but we are the referral center for Moose Factory in Northern Ontario. And so we receive consults, requests for many patients with liver disease from remote areas, and we will bring them to Kingston. We will telemedicine with them. If they have to come for an RFA or TACE, then we fly them down. They stay overnight. We make arrangements for those patients. So I think the best thing you can do from a patient and caregiver perspective is really advocate that you get in contact with a liver specialist. And your own community hospital should have a referral center, which should be able to discuss your case within a tumor board to help you figure out what the best treatment is for you.
Oh, great. Thank you for that. One question popped up in one of our feeds in terms of some of the side effects with either liver cancer as a condition, but also with some of the side effects from treatments, whether that may be some of the chemotherapies or some of the oral drugs. And they're wondering, how do you stop or how do you control the fatigue or the tiredness associated with either the condition itself, but also with some of the side effects of medicine?
Well, unfortunately, many of the chemotherapy side effects are, they cross across multiple disease sites. Fatigue, tiredness, that's very common with a lot of the chemotherapy regimens. Again, it's to the basic principles of trying to stay active, eating healthy, exercising. These are some of the ways that you can getting good sleep. These are some of the ways that you can battle that fatigue. Obviously, having good mental health and keeping up your spirits despite a prognosis of cancer are also very helpful. Now, you asked previous to that a question about what do patients with liver cancer feel? Well, I think it goes back to what Dr. Flemming was saying. Well, it depends on if you're decompensated or if you're compensated. Usually the patients that are compensated don't feel anything. Usually liver cancer does not give pain unless it's massive or you do a decompensation as a result of the liver cancer. And at that time, we're trying to work quickly to get you into treatment and seeing what can be done at that stage.
Dr. Flemming, anything to add on your end?
Yeah. No, I would just like to say that the symptom of fatigue in patients with liver disease is very, very common. And I wish I had a magic solution for it. And I agree with everything Dr. Brahmania said, that there's no magic bullet for it. It's kind of a multiple different things that can help. And I would reiterate, the trying to stay active, getting good rest, and eating healthy are key.
Great, thank you for that. Another question about on some of a specific kind of cancer, maybe perhaps some treatment, how treatment differs with different or numerous benign tumors. So his question was, what's the probability that liver cancer will or may eventually develop in someone who has hepatic adenomatosis? And how would cancer treatment differ when numerous benign tumors are also present, or if treatment does differ?
So I'm not quite sure. I'm going to try and clarify the question. I think they may be referring to hepatic adenomas.
Yes.
So hepatic adenomas are potentially precancerous lesions that develop in individuals who don't have cirrhosis. So they're a bit of a different entity, but typically depending on the size of the adenoma, that you may be offered resection based on the size, because the risk of transformation to liver cancer in hepatic adenomas is based on the size. So that's usually a discussion that occurs with hepatobiliary surgery, who will make the diagnosis and follow these lesions. Sometimes they're also treated with other modalities that Dr. Brahmania said, such as RFA. But the typical individual who has an hepatic adenoma is a female patient because they are very responsive to estrogen. And so sometimes individuals with adenomas, there's also discussions about contraception, what to do with that, and those are followed. But hepatic adenomas are very distinct distinct from a hepatocellular carcinoma. Even though the adenomas can transform into cancer, it's a different clinical scenario.
Oh, great, thank you. Dr. Brahmania, anything to add on your end for that? I think another question also popped up in terms of cholangiocarcinoma, bile duct cancer, and its kind of relationship to HCC or liver cancer, and if the treatment differs for some of these different sites of cancers within the bile duct and liver kind of area.
Yeah, very difficult question. Cholangiocarcinoma is a very aggressive bile duct cancer, as you're mentioning. There's many different treatment modalities. Mostly it's chemotherapy where we're trying to shrink the tumor to try to get it into transplant criteria. We have specific criteria that I'm not going to get into, but if the tumor gets below a certain criteria, then we may be able to provide liver transplantation. That's of course if the size is small enough and there's been no extra hepatic spread or any metastases to any other organs or even within the liver. Usually though, if that happens, then the cancer is inoperable or incurable, and you're looking at palliative treatments. There's a lot of research going on in this type of cancer. We are finding that the incidence is actually rising and we're recognizing it more. So this is definitely a growing need in terms of research.
Oh, great, thank you for that. I guess it kind of the whole spectrum of some people who reach out to the CLF, they're either had a family member who had HCC and they're kind of wondering from a genetic perspective or if it's hereditary, if perhaps somebody had a liver condition or liver disease or advanced liver disease, and they're wondering if they're at more risk if they don't check the boxes off some of the other risk factors, if they're considered at risk for either advanced liver disease itself or HCC specifically. So that was kind of the one question popped up. Hereditary risk factor, does that play a role?
So as I mentioned earlier, the biggest risk factor for HCC is having cirrhosis. However, there is some studies looking mostly at patients with hepatitis B, who, if there is a family member with hepatitis B who had liver cancer and you have hepatitis B, that your risk is thought to be higher. The question I'm wondering if the question from the audience was, if you have a family member who has HCC, but you have a normal liver, are you at risk of HCC? And the answer would be no. However, if you have a family member who had HCC, they likely had cirrhosis. And therefore, if you have cirrhosis as well, you're going to be at risk. But if you have a normal liver without chronic liver disease, even if you had a family member with HCC, there's no studies suggesting that your risk is higher and that you need to be screened. It's really only individuals with known cirrhosis or patients with hepatitis B who don't have cirrhosis. Otherwise, the risk is extremely small.
Brahmania, anything out on your end?
That was an excellent answer. I would just add that the fastest growing cause of cirrhosis and death and liver transplantation and HCC is a disease called NASH, non-alcoholic steatohepatitis. So I agree with what Dr. Flemming said, but if you do have risk factors like diabetes, obesity, hypertension, sleep apnea, that you may be at risk for chronic liver disease and or cirrhosis and eventual complications, as was highlighted in the talk by Dr. Flemming earlier. And so how would you screen for that? Well, you would follow up with your family physician and get yearly checkups, as most Canadians should. And we have screening tests such as liver enzyme tests that can be looked at, and if they're elevated, this deserves further attention and further workup.
Great. I'll ask this kind of final question here from a outlook or down the road perspective. So looking down the road, what areas of research in liver cancer do you think are important in improving or prevention, treatment, and quality of life for liver cancer patients? So what areas of research in liver cancer do you think are important at improving those prevention, treatment, and quality of life? It's kind of like a final positive outlook as to what the field is looking at and what maybe you both from your professional experience see down the road.
I think moving forward, the medical field is really moving towards precision medicine, or giving the best treatment for the individual patient. And that's developing not only in liver cancer, but many other cancers where certain characteristics of your tumor or your liver may be able to determine which treatment you're best going to respond to. And so I think what we're going to see over time is that we'll get better at defining individuals' risk of liver cancer, because we know if we take a mixed population of patients with cirrhosis, certain people are at higher risk of liver cancer than others. But we haven't yet really defined with accuracy or ease who are those at highest risk. And maybe we would change our surveillance practices based on that. And similarly, once a diagnosis is made, what factors within the tumor or the patient themselves may influence which treatment is best, whether that be chemotherapies or immune therapies or all these other types of treatments that are evolving.
Dr. Brahmania?
Yeah, similarly, I think that's an excellent area of medicine. For me, the interest for me is how can we screen better, identifying patients with chronic liver disease that is largely an asymptomatic disease, and getting those patients and recognizing them and entering them into surveillance programs. There's numerous literature out there right now that the patients that have been diagnosed do not get 100% screening all the time. And so how can we as an organization increase screening rates from 30 to 40% to 80%? I think with that being said, if you have more people screened, then you can detect cancers earlier and get them into more treatable cancers. I think another area that I kind of alluded to in my presentation is when you're looking at the Barcelona clinic liver cancer staging system that I showed, is how do you move these patients that have presented on the right side of the curve or a middle of the curve to the left side. Now there's a lot of research going on in terms of using different combination of therapies such as TACE or radiation therapy, including it with chemotherapy, and then trying to what we call downstage the tumor or shrink the tumor into a treatable situation such as ablation, resection, or liver transplantation. And so this is definitely an evolving field. It's already taken leaps and bounds from where we were about a decade ago. I think in the next decade or so, the paradigm will shift dramatically, and hopefully we'll be able to get more patients into curable treatment options.
Oh, perfect. Thank you for that. And with that, we'll conclude our webinar for tonight. We've definitely got a lot of those questions in the last few minutes there. I would like to take this time to thank our medical experts, Dr. Brahmania, Dr. Flemming, for the wonderful and informative presentation and talk. I also want to extend my thanks to our partners, the Canadian Association for the Study of Liver, for helping with this webinar. And as mentioned earlier, this webinar will be available on the CLF Facebook page, website, and YouTube pages over the next few days. And of course, to learn more about liver cancer and all other liver diseases, or to find out about the Canadian Liver Foundation, please visit liver.ca, and please be sure to follow us on social media. It's our Facebook, Twitter, and Instagram pages for all the most up-to-date information and liver health tips. Once again, thank you all for attending tonight, and we hope you have a safe and wonderful evening.